Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project ECHO Session 8. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington. We're so excited for this ECHO program to continue. For every session, we do ask you that you help us empower our patients living with cardiometabolic disease. And note, this is a safe space and that there is zero tolerance for making people uncomfortable, because we're really building this learning community together, which is really the heart of the ECHO model. So now our agenda for today. We're really excited to have Dr. Laura Montour, who's our obesity expert and also a family medicine physician and the director of our weight management clinic here at the University of Washington. And, we have this common theme. So the lectures today is going to be beyond glycemic control, but in this case, it's about promoting weight loss by using glucose lowering agents. And then we'll have a great case from one of our own UW endocrinologists in training, Owen Thompson. So we're really looking forward to that. I'm going to have the panelists introduce themselves now, and I'm going to start with Laura. So go ahead, introduce yourself.
Hi, everyone. It's good to be back. Again, I'm a family doctor and obesity specialist and currently the co-director for our UW clinic. And again, I'm happy to be here again.
And now, Faiza Alibi.
Thanks for having me, everyone. I'm Faiza. I'm one of the pharmacists at the UW Diabetes Institute and Lipid Clinic.
And finally, Owen, do you want to go ahead and introduce yourself as well?
Yeah, thank you. I'm Owen Thompson, one of the endocrine fellows at UW, second-year fellow. Thanks.
Perfect. And now, without further ado, go ahead, Laura Montour. Take it away and start our great didactic.
Great. So today, as Nicole mentioned, we are going to be talking about beyond glycemic control, so promoting weight loss using glucose-lowering medications. I did not have any disclosures to mention today. So our objectives, we're going to cover a few things. We're going to identify some preferred medications when we do want to minimize weight gain or promote weight loss, but we're also going to talk about options to combine therapy if our A1C is above target. But we're also going to explore and touch on which diabetes medications promote weight gain versus weight loss. So as we start, I definitely want to make sure that everyone is kind of on the same page in terms of, I guess, how obesity and weight management is such a complex disease, as complex as obviously type 2 diabetes. And when we simplify managing weight as eat less, move more, that is definitely an example of a healthcare stigma against obesity. So we're going to learn a little bit more about why I'm saying this, but I do want everyone to be kind of moving away from kind of this blanket statement in terms of weight management as eat less, exercise more. So this is a visual that I created, but it's this. What you're going to hear is basically every single patient that I meet with that I talk about when we're talking about weight management. But when we gain weight, and we know many things affect weight, obesity is multifactorial, but our body unfortunately always remembers our weight at its highest. And in obesity medicine, we refer to that as a set point. So once we start doing any intervention to start reducing weight, we have to start basically defending against our body because our body will try to pull us back to that set point weight. Several things happen to cause this, but we know that with weight loss, our metabolic rate starts reducing, so the body adapts itself to take less calories. But our body also will start increasing hormones that cause us to get hungrier. Specifically, we get a ghrelin increase from the stomach, but also some of our intestinal hormones that normally get released to help us to feel full, those also start to decrease. So as you can see in this visual, the person pulling this kind of huge weight, it's supposed to be kind of pulling it up a hill, but these are pretty strong forces that we're kind of navigating against when we're trying to reduce weight and maintain weight. So this is why this is, again, much more complex than just eat less, exercise more, because our body is defending this elevated fat mass set point. And there's no tool or surgery or medication that can reset the body's set point. So it's very, very important that whatever plan that we initiate needs to be sustainable and long term. So I'm going to talk about weight management in particular in terms of 3 steps, but we'll kind of go through within those steps. And we're going to get obviously to the meat, which is talking a little bit about some of the anti-obesity medications, but we want to have a diagnosis. And Everyone is familiar, I'm sure, in this panel that we've got a BMI, body mass index, to break down this diagnosis. This is probably going to be evolving because, as many of you all also know, BMI is not an accurate measure of health. It doesn't account for muscle mass, which is very, very important for supporting metabolic rate. It doesn't account, muscle weighs more than fat, but it is the easiest tool that we have. It's part of our guidelines that we do have to use, but I would definitely use it with caution because, again, it doesn't necessarily give us the full details of what's happening in the body. But overweight would be BMI 25 to 29.9, class 1 obesity 30 to 34.9, class 3 obesity 35 to 39.9, and class 3 obesity would be a BMI over 40. And I just wanted to make everyone aware that there are cutoffs, different cutoffs that are lower for Asian American specifically. So please, interpret BMI. You all also want to be aware of the ethnic cutoffs. So after we get our diagnosis, we've established BMI, we want to assess the stage of obesity and we want to evaluate for complications. So whether someone has overweight class 1, 2, or 3, they may have various stage 1, 2, or 3 obesity. Stage 1 would be that there are no obesity related complications. Stage 2 would be one or more obesity related complications. And stage 3 would be one or more severe obesity related complications. And below that, I've listed the various complications that exist, but prediabetes, dyslipidemia, hyperlipidemia, of course, type 2 diabetes. I don't think I have it on there, but type 2 diabetes, non-alcoholic non-alcoholic fatty liver disease or metabolic associated fatty liver disease, heart disease. There's many: heartburn, asthma, PCOS, hypogonadism, reduced fertility. So again, after you establish, BMI, what is where does the patient fall in terms of class 1, 2, 3, or overweight, but what is their stage 1, 2, or 3? Step 3 is after we've again established a diagnosis and severity in terms of assessing what stage a patient is at, we want to implement the plan. And it's going to combine two kind of major components. Lifestyle is going to be paramount, regardless of what tools. We're going to have some lectures coming in the future that are going to go in more depth with this. So I'm not going to spend a lot of time, but I do want to just highlight that it's an important part of diabetes and obesity treatment. Lifestyle intervention is usually multifaceted. Nutrition is going to be part of it, physical activity, sleep, counseling potentially, smoking cessation. And lifestyle treatment may involve multiple team members: primary care, dietitian, of course, endocrinologist, sleep medicine. So again, it's multifaceted and multidisciplinary. But our other component is going to be medication or surgical tools in terms of, tools. And I left this comment here at the bottom, which I'm going to explain a little bit more detail, but your treatment intensity is going to depend on the stage or severity of obesity. And today I'm going to be specifically focusing in on these medication surgical tools. So medical therapy for patients with overweight and obesity, two strategies. Number one, we want to choose glucose lowering medication, but we want to choose them in a way that we choose them in terms of how they affect weight. There are many medications that can cause weight gain. So we want to, again, choose tools that are going to be weight neutral or support weight loss, but also we want to evaluate for other medications that may contribute to that. Two, we're obviously going to potentially consider maybe layering or adding on therapies in addition to the glucose lowering medication. And we would specifically consider anti-obesity medication if the BMI is over 27. And when we do choose an anti-obesity medication, we do want to individualize the choice based on what, patient preferences, et cetera. But efficacy, safety, but also cost can be a barrier. And then going back to, I mentioned, what treatment tool depending on the stage. So this is a great chart that I reference also very frequently in the office with my patients, but it gives us a breakdown of what percentage of weight loss we want to target in terms of what maybe comorbidities we're trying to target, or, obviously we're working with patients with diabetes, so we, want to achieve certain percentages that we know are going to help with reduction in A1C and help potentially reduce need for some medications. But just generally across the board, you can see on average, even 5% of weight loss is going to have a significant health improvement. But our goal that we choose with the patient may depend on what other comorbidities may exist. But generally, 5% to 15% is going to be an ideal target for our patients with diabetes. So this is a chart that I've included for reference, just showing the different medications that are out there that do cause weight gain. As you can see, there are some diabetes medications. Insulin in particular can be weight promoting, the sulfonylureas, but there are many antidepressants that patients may be on that could be causing weight gain, antipsychotics, of course, steroids, glucocorticoids, beta blockers also could be potentially weight promoting. So it's not always perfect in the sense that, we identify these and we can stop them, easily. So, if you do identify these medications, if there is an alternative, certainly I would recommend doing that. But sometimes we're just looking at, risk benefit and, of course, some of these mood medications are very, very important for patients. So we may not be able to make changes. But I just want you to be aware that this is a really a key area that we may be able to help with weight management by just screening or potentially getting rid of medicines that cause weight gain. So we want to choose diabetes agents, as I mentioned earlier, that are weight neutral or cause weight loss. So weight loss, we can generally see some very mild with metformin, I'd say 3-5%. The SGLT2 inhibitors, there can be some weight loss, or GLP-1 receptor analogs, which we've heard a lot about so far in this program, GLP-1 receptor analog, GIP medication. So if we can choose those medicines, that would be preferred, especially when we have a patient with obesity. But you also may consider other weight neutral options listed here. But the one key takeaway, and again, it was highlighted in the last chart I put for you guys, insulin and those sulfonylureas, those can be weight promoting. So if you're layering them on for a medication or layering them on for a patient with obesity, it just may make their weight management a lot harder. So this is a chart that I've taken from the Obesity Medicine Association, and it needs to be updated because our tools are getting better and better. But this is another, I think, guide that helps kind of, that you want to share or discuss with patients when you're choosing tools, depending on what goal you want to lose in terms of the health goal. So when people do lifestyle modification, on average, weight loss is about 2 to 5%. More intensive nutritional interventions like diabetes prevention program or intensive dietitian, Weight Watchers, and Noom and things like that, we may see up to 10%. When we layer pharmacology onto intensive lifestyle, we can get much more weight loss, and on average you're going to see a chart in a few slides just kind of laying that out, but on average about 10%. But some of these newer tools we can even get up to 20%, maybe more. Endoscopic therapies are also potentially a surgical tool that could be considered, and that's going to maybe give you a little bit more weight loss. But metabolic and bariatric surgery, if your health goals are going to be higher than 25-30%, that ultimately may be the best tool for that patient. So this is a really busy slide, but it's a good reference for you to have, which goes over all of the different anti-obesity medications that we can use for patients with diabetes when we're wanting to reduce weight to help with achieving A1C goals. I'm going to talk specifically about the naltrexone bupropion in a bit, and I'm going to talk about phentermine. But what I want you to take from this is just kind of looking at a sense at the percentage of weight loss that we see. So again, on average, a lot of these tools, it's about 7 to 10% weight loss. Orlistat, I'm not going to talk in detail about, but it is, you can get an over-the-counter version of it, but it generally is not a tool that we use a lot in obesity medicine just because of the side effects. And what it does is it decreases fat absorption, but it still could result in, a meaningful weight loss, but a lot of people can't continue to take this medicine because of the, GI or anal leakage and things like that kind of side effects. So I did want to make you aware that it's available, but as we mentioned in the very beginning, we want our plan to be sustainable and long term. And this orlistat may not be necessarily a long-term feasible option for patients because of those side effects. The other thing I just wanted to point out, I'm not going to spend a lot of time talking about GLP-1 receptor analogs and GLP-1 GIP treatments because we've heard a lot in this ECHO program. I'm going to talk about some special considerations, but on average, again, with Saxenda or the liraglutide treatment, up to percent weight loss, 6% kind of quoted in this article, but on average about 10% with a lot of these tools. Hypoglycemia can be a risk with the GLP-1 receptor analogs, especially when patients are on insulin or sulfonylureas. Has been reported as well, but there hasn't been necessarily a causality established. And you want to be careful in patients with kidney disease because of, dehydration in particular, when people really eat a lot less. But common side effects that we see with these injectables are nausea, vomiting, I'd say constipation, diarrhea, heartburn. And then semaglutide and our newer tool, tirzepatide, we're just seeing greater weight loss, but they all have similar side effects. But also, all of these tools, there's a black box warning about risk of thyroid C-cell tumors in rodents, but we haven't established that in humans, but it was in mice studies. And we would not use these medicines if there's a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia. And then I just also wanted to point out gallstones, because that's another, we can see gallstones happening with some of the other medications, but in particular, it is a risk with these injectables because the gallbladder does empty a little bit slower, but also the rate of weight loss sometimes can affect gallstones. So phentermine is a sympathomimetic amine that came out in 1959. So it's a really, really old medication, and we're still talking about it in 2024 because it's just really inexpensive. On average, with various coupons, you can get it for as little as $15 a month, but it is a very, very old tool. It is an anorexin and central nervous stimulant. So it is, as you can imagine, in terms of side effects, it's going to be a stimulating tool. And one important thing to note about phentermine, however, is it's FDA approved for as a short-term adjunct. And that's a very vague term. Like some people would say 12 weeks, some people might do 6 months, some people might do shorter, but generally it's approved as a short-term adjunct, which is hard to reconcile when we're doing long-term weight management because obesity is a chronic metabolic disease that requires long-term treatment. So again, we are limited a little bit by that FDA approval, but it still can be used. We generally want to individualize treatment to get a response with the lowest effective dose, and tolerance can develop with phentermine, and that usually happens within the first month. There are different ways to dose phentermine. It comes in a tablet, 37.5 tablet. It comes in a capsule, and it also comes in another tablet, a lower dose of 8 milligrams. And choosing the tool really depends sometimes on availability. There have been sometimes shortages of the capsules, and then the pharmacy will request a tablet. So that's definitely one of the reasons you may choose. But the 37.5, I think, is commonly used a lot in obesity medicine because, if patients are paying for it with the tablet, they can break it in half. And, if they break it in half, they're going to be able to do 18.75. So it's a little bit more cost savings doing that tablet versus a capsule. But sometimes the choice, I think, just is a matter of what's available at the pharmacy. There is this 8 milligram. It's a newer version of phentermine that can be dosed prior to meals. Because the one issue that sometimes can happen with these medicines, the phentermine, is it can wear off during the day. And if you take phentermine later in the day, because it's a stimulant, it could affect your sleep. So sometimes using this lower dose may be advantageous in patients where they find that it's wearing off towards the later in the day. And because this is a stimulant controlled substance, we definitely want to be avoiding phentermine in patients with a history of substance abuse. There isn't a dose adjustment for liver impairment, and for renal impairment, there are some restrictions, but generally we can still use it even up to eGFR of 15 to 29, but you aren't going to want to push the dose too high. but also if there's severe kidney disease, we just don't have the data. It hasn't been studied, as well as in end stage renal disease. And we would not use the contraindications to phentermine would be if someone has a history of, I'd say, active unstable cardiovascular disease. So, recent heart attack, uncontrolled hypertension, heart failure, arrhythmia, recent stroke, hyperthyroidism, glaucoma, history of drug abuse, as I mentioned, or if a patient's been on a MAO inhibitor, or if a patient is pregnant breastfeeding. And I wanted to put this up because I mentioned that, long term, the FDA only approves phentermine for as a short term adjunct, but in the real world, we, providers, especially in obesity medicine, we do use it longer, although it's off label. But there is this retrospective study that looked at an electronic health record of a huge number of patients from 2010 to 2015. And the doses of phentermine were quite variable, but they looked at patients who were taking it for short term, like 12 weeks, versus off label, longer than 12 weeks. And they compared percent weight loss and risk of cardiovascular death. And what they found was that when people were using it off label, longer use, they actually had a higher amount of weight loss, and there was rare cardiovascular risk or death. And the longer term phentermine group over time had lower systolic blood pressure. Again, it's not the highest quality, but it is a really important study that we reference a lot in obesity medicine because it does show that there is that safety. And the other article that I wanted to bring up, because I get a lot of, even as a PCP, when I first started prescribing phentermine and reading about because it's a stimulant, you think about addiction. And so this is another highly referenced study that we use a lot in obesity medicine. And it was another retrospective study, again, using an electronic health record. Actually, this doesn't show the right data, but what they found, and the doses of phentermine that were used in this clinical trial were even like 90, 100, like super high doses. And what they found was, and when they actually gave these different like amphetamine craving or cocaine craving scales to patients, and there was actually a very low risk of addiction or craving in patients that were on even higher doses. But again, you still would be very careful about prescribing this for someone who has a history of addiction. So addiction potential is actually, it hasn't really been seen again in this study. So just to get everyone engaged a little bit, I know it's kind of hard in the setup to do kind of a question answer in real time, but we have a patient here, a 54-year-old woman with obesity. She has a BMI of 45, type 2 diabetes, and she's been on metformin 1,000 milligrams twice a day, and she's following up for her routine diabetes care. Recently, she reported that her weight increased by 10 pounds and she was getting a little bit more back pain. She just had gabapentin prescribed by her sports medicine doctor 3 months ago, but it hasn't really been helping her pain. Her A1C today is 8.5% and her blood pressure is 150 over 90. She desires weight loss and thinks her weight is worsening her back issues. What would you recommend? So, A, we should discuss with the sports medicine doctor alternatives to gabapentin. B, she should just eat less, exercise more. C, she should continue her current treatment plan without any changes. D, she should start basal insulin. Or E, she should start phentermine. So hopefully kind of hearing from the few slides that we've gone through already, definitely we can all say that gabapentin could potentially be, one of these triggers for her weight gain. So it definitely could be, I think, a good option to consider for her. I hope no one is thinking she should eat less, exercise, move more, because like we talked about, weight management and obesity is more complex than that. So definitely B would not be the correct answer. She should continue her current treatment plan without any changes. Well, probably not. Like we probably want to get her A1C a little bit, a lower target for her, and her blood pressure looks like it's going up. So we definitely don't want to. So C, I would say, is not going to be correct. Insulin, I guess we could think about that, but her A1 over 9 potentially, we may, as you've heard from a lot of the other sessions, that's maybe when we think about it. But probably not either insulin because, that might just make it even harder for her to lose weight. Or E, she should just start phentermine. That may, I think it's a thought, but as we discussed with phentermine, her blood pressure is actually not really well managed. So we definitely want to, I would avoid phentermine in this patient because of the uncontrolled. So I would say the best course of action, at least in the beginning, would be probably to maybe explore other options to gabapentin. Of course, I think one of the questions is, yes, we could think about the GLP-1, GIP, all those other things, but I want, again, kind of grasping the concepts that we've talked about. I wanted you just kind of take that weight promoting medications. That's definitely a good place to start, especially if she finds it's not working. So phentermine and topiramate is combined in an extended release formulation, also called Qsymia. And even though it's phentermine, it was actually approved by the FDA for long-term treatment of obesity. So I definitely feel that there's a lot more comfort in primary care considering this tool if it's covered because it is actually approved for long-term and you're not doing the off-label prescribing of phentermine. But it's going to work very similarly to the phentermine by itself, but it's going to be an extended release, but it's still a stimulant. The topiramate part of the phentermine is a nice adjunct because the topiramate has a nice effect on dopamine and kind of that reward part of the brain. Together, they are going to have a nice effect to reduce appetite, but I find also patients do have a benefit for reducing cravings and that kind of reward part of eating. The topiramate in particular, that part of it can also make soda and things taste flat. So patients who are maybe drinking a lot of sodas and things, adding that sometimes can help reduce that as well. With the topiramate, so the same side effects are going to apply that we talked about with phentermine, but for topiramate, brain fog is a common side effect, numbness, tingling, and you want to be careful if you're combining it with hydrochlorothiazide. There can be effects on potassium and with lamotrigine as well. So if patients don't have coverage, which many unfortunately don't, there is a savings program through the company, and you can get the combo medication for $100 a month, and it's delivered right to the patient. Generally, with Qsymia, same as phentermine, we start low and then we gradually build up. So the starting dose is 3.75. We do that for 2 weeks, and then we go up to the 7.5, 46 milligrams if they're tolerating it. And then we'd keep them there. After 12 weeks, we would reevaluate. If the patient hasn't lost at least 3 to 5% weight loss, we probably would say, let's look at other tools. But if they did have some response, but we want to still get further weight loss and they're tolerating it, you can also increase it up to 11.25, 69 milligrams for 2 weeks, and then go to the 1592 milligrams as well. And then the other tool that we have is bupropion naltrexone, also called Contrave. Bupropion, many of us are familiar with. It's a dopaminergic. It's also used for depression, anxiety, quitting smoking. Naltrexone is an opioid antagonist, and in the hypothalamus, where we control appetite, we actually have opioid receptors. So by blocking that opioid receptor together, they help reduce appetite, but they also, I feel like this tool is really nice for patients who have more of a reward drive to eat. Savings program is very similar. So it's about $100 a month. This regimen with Contrave is pretty labor intensive for the patient. Like they have like one pill, they start one pill in the morning and then they go up to one pill twice a day and then two pills. So I don't use the brand a lot because of the pill burden, and we can definitely prescribe these separately. So I wanted to make you aware of it. But again, in real life, I would say most obesity specialists were prescribing it separately. But there have been a lot of shortages of naltrexone around. So unfortunately, some patients we've had to go to Contrave because of these shortages. Elevated heart rate and blood pressure, I would say, are pretty common side effects. And this is one of the reasons I've had to actually take people off because their blood pressure just is not well managed. So you definitely want to monitor heart rate and blood pressure, and then constipation as well as a common side effect. And again, I'm not going to spend a lot of time talking about our other like GLP-1 and GIP, but I just wanted to show you this image to kind of just really give you a snapshot of like all of the complexity going on in the body in terms of how the body responds to food intake and the connections that exist between the pancreas, the fat tissue, the brain, and what we're going to be seeing in the future is we're just getting a lot more tools that can target more of these pathways. So, it's a really exciting time in terms of obesity medicine and type 2 diabetes, because we're going to have a lot more of these options. And the general term that you're going to be hearing is, I know we all say GLP-1 medications, but incretin therapies, I think, is what you're going to be hearing, just to kind of, because there are going to be various ones coming. But these are hormones that get response when we eat food. And these hormones, when they get secreted, they can basically adjust how much food we take in. Some of them may actually help with energy expenditure. So again, it's a really exciting time seeing how these tools are going to be used in the future together. So, and then question number 2, which of the following is a significant safety concern for GLP-1 peptide receptor agonist? Gallstones, papillary thyroid cancer, risk of amputations, increase in cardiovascular mortality, or kidney stones. So, kind of going through that big chart that we saw earlier, the gallstones, yes, for sure, that is one of the things we can see. It wasn't papillary, like when we in that chart, it was medullary thyroid cancer, so B would be incorrect. Amputations is not a risk of any of our weight management medications, but as we heard from our lecture last a couple weeks ago, the SGLT2 inhibitors, that would be associated with them. There isn't actually an increased cardiovascular mortality with these medications, and as we heard from some of the sessions earlier, we see benefits. And kidney stones is not a risk. However, with topiramate and that Qsymia, that could increase risk of kidney stones. So gallstones is going to be our most significant concern out of this group with the GLP-1 receptor analogs. And I want to mention bariatric surgery. I know we're talking about medications, but bariatric surgery is a surgery that should be considered in all patients with diabetes. There are large trials that have existed that show direct comparison. And in particular, in the STAMPEDE trial, diabetes remission rate is much higher with surgery versus medication. It's not for everyone, obviously, but I think just with the significant impact that surgery can have in achieving remission, it should be considered. I guess just in general, sometimes it depends on insurance coverage, but a lot of insurances may cover surgery, but they don't cover some of the medications. But I just want to, take time to read through this, but it's a very important tool. So other considerations with combination treatment for diabetes and weight loss. So we may need to adjust insulin, and we've heard this before with some of our other cases we've had, but we may need to adjust insulin because of the risk of hypoglycemia. Also, blood pressure can start to go down, so you may have to be adjusting medications for their blood pressure because that usually will improve with weight loss. But I also want to go over this really hot topic right now, which is muscle loss. And we see a lot of muscle, like various things affect muscle. Aging, definitely when we're, eating restricted calories, nutritional causes, GI, like some of the medications and the GI side effects, inactivity, weight cycling, type 2 diabetes can impact that. So there are many things that can impact that, but definitely when we're using these medications in our patients with diabetes, it's something that we have to be concerned about. And so this is not with diabetes, but in the step 1 trial with semaglutide, there was about 10% muscle loss. And in the SURMOUNT trial, after 72 weeks with tirzepatide, there was about an 8% loss of muscle. So when we are treating or doing weight management for our patients, whether they are on medications or they have surgery, we want to, of course, reduce obesity complications and reduce some of the health risks associated with the adiposity. But a really important goal that we want to have is preserving muscle mass. And again, you're going to hear more in other sessions about the nutritional therapy, but I did want to point that out. And muscle in general is more metabolically active than fat tissue. So when we lose muscle, as we talked about earlier with how the body adapts in set point, metabolism is going to slow down. And if we're losing muscle on top of that, it's just going to make weight maintenance harder. And we can get this weight cycling happening, which is going to, further contribute to muscle loss. But but patients will regain weight. So very, very important that, in addition to lifestyle, protein and the cardiovascular activity, patients should be encouraged actually on weight management and on these treatments to do resistance exercise at least 2 days a week. So last question, which of the following is true? Phentermine should not be combined with diabetes medications. Insulin causes weight loss. C, once weight loss is achieved, patients should stop weight loss medications. D, resistance exercise is not needed when using anti-obesity treatment, or bariatric surgery should be considered in patients with obesity and type 2 diabetes. Well, we've already seen in various slides that we can layer these medicines on. So phentermine can definitely be combined, but we want to be careful about hypoglycemia. We've already seen also in a few of these slides, insulin actually causes weight gain, not weight loss. So B would be incorrect. And as we've seen earlier in that slide about how the body adapts and set point, our plan needs to be long-term and sustainable. So once a patient gets to their weight loss goal, they need to continue their treatments, because if they stop, their weight's going to go right back up. And as we've just seen in the last slide, resistance exercise is very important to preserve muscle mass. But as we saw in one of these slides earlier, bariatric surgery could be a feasible treatment for treating diabetes, so it should be considered. So lifestyle treatment is critical for weight management. You want to consider the implications of weight gain with any medications you prescribe for patients with diabetes and obesity. And you always want to be considering using weight loss or weight neutral diabetes medications when possible. But don't hesitate to use your toolbox of anti-obesity agents for patients with diabetes and a BMI of 27 and over. And you can combine these treatments to maximize weight loss and lower A1C. Resistance exercise is critical to help preserve muscle mass during weight loss, and bariatric surgery should be considered as a treatment tool for patients with type 2 diabetes.
Laura, thank you so much for that great presentation. As we pull up the case report, I will ask one question of you, and that is, when and where do you add the medications as an adjunct? Do you do it at your first visit with a patient, or do you focus on lifestyle and then at the next visit or over time add an anti-obesity medication?
So when I'm thinking about adjunctive tools, I'm thinking about, what is the stage of, like, what is their level of obesity, stage of obesity? Because I think the way we level or layer these tools on depends on, what is the goal we're trying to achieve and what is their severity of disease. So the same as I wouldn't ignore a hypertensive emergency, I would not, withhold treatment from a patient who has a BMI of 40 and stage 2 obesity. So, or a BMI of 27 with, multiple comorbidities. I consider it at the first visit. I'm not withholding it. Again, we need to manage this as a chronic disease. It's like high blood pressure. However, sometimes insurances require patients to try and fail lifestyle for 3-6 months before they will cover them.
That's a great point. A lot of our questions always seem to be related to cost and coverage. And so sometimes knowing those nuances help set the stage for our patients and make them more successful and not get frustrated, just like we know we sometimes are for them. So on that note, we'll go ahead and ask Owen to start our great case. So go ahead, Owen, take it away.
The patient I'm going to talk about is a 56-year-old gentleman who came to see us at the Diabetes Institute late last year. At the time, the reason for his referral to us is that he's originally from India. He's a farmer there, came to the US to sort of join his daughter who had come to the US. And in India, he knew that he had diabetes. He had been on metformin in the past and had sort of failed that for GI upset. And then on arrival to the US, his first sort of establishment with healthcare, he had a creatinine of 11. And so he was sort of rapidly moved over into seeing nephrology, and biopsy showed some combination of diabetic and hypertensive nephropathy. Was placed initially on dialysis, but then underwent a renal transplant about 7 months before he saw us. At the actual transplant time, he was not on diabetic agents. His A1C was 6.5. He eventually, he has other comorbidities in addition to the type 2 diabetes, obviously hypertension. Those are the two underlying contributors presumably to his end-stage renal disease. Also has GERD, hyperlipidemia, and obesity with a BMI of between 30 and 35, depending on when you look at his history. So he's referred to us for diabetes management because post-transplant, he has been noted to have worsening diabetic control. So his past medical history, obviously we have end-stage renal disease due to the hypertension and diabetes. He's post-transplant now. Comorbidities we've talked about. He does have anemia of CKD, does have some BPH, and then when we see him, his BMI is 31. Current medications, we're going to see some transplant medications on here, but also hypertension and diabetes medications. So he's on amlodipine, atorvastatin 10. He is on famotidine, and you'll see omeprazole down here. I think one of these he takes PRN as a secondary agent for his GERD in the setting of poor control there. He's on gabapentin for a prior knee injury that caused left lower extremity numbness in the midfoot. It's kind of unusual history, but does take nightly gabapentin for that reason. And then his diabetic regimen, when we see him, is glargine 37 daily, and then mealtime aspart 8 units within a correction scale that we would say is a medium correction scale, 2 units for every 50 points above 150. He is not on a CGM when we see him. He does some of this. He does a lot of this with point of care checks and is assisted greatly by his daughter in this setting. His transplant medications, also the tacrolimus 3 milligrams BID, prednisone 5 daily, mycophenolate 360 BID. And he does take some PRN oxycodone because his post-transplant course has been complicated by a sort of abscess/hematoma that is resolving. It's improving, but it's been a post-transplant complication overlying the kidney transplant site. He does have a prior intolerance to metoprolol. I think this is I didn't officially mark metformin intolerance on there, but he endorses prior difficulties with metformin with similar side effects to these. He's initially obviously from rural India. I didn't get a great history or dig extensively into where and all those things, but he endorses a negative family history for diabetes, but both of his brother and sister have diabetes or pre-diabetes at least. There's no family history of heart disease. We talked about him being a farmer before coming to the US. He is married, doesn't smoke, has very scant social alcohol use, but essentially no alcohol use, nothing for 20 years. When we see him, his initial vitals for us, he is mildly hypertensive at 146/73 with a BMI of 31. Recent panel that we got prior to seeing us, he has a glucose of 113, obviously on a random basic panel. His A1C is 8.2. That's up about 2 points from 6 months prior. That post-transplant escalation in his in his chronic hyperglycemia. Creatinine's okay at 1.01, and then in terms of a cholesterol panel and triglycerides, he does have an LDL at 62 and mild hypertriglyceridemia at 210. So he's obviously followed closely by nephrology, and so there is albumin of 29 on a microalbuminuria screen. So the notes here that his A1C, I'm just going to highlight this, has recently gone from 6.6 initial post-transplant to now 8.2. And again, we don't have any continuous glucose monitoring, but we do have this sort of scatter shot of glucometer data, and he doesn't officially bring in any technology to that end. It's just, his reports of what his glucometer's been doing. He thinks that sometimes after a little bit more physical activity, he feels symptomatically feels like he's having lows, but when he checks, those are only about 80 milligrams per deciliter. And we did see some numbers in that range on his glucometer. We did a foot exam at our visit. There's this sort of unusual midfoot equivocal neuropathy, but no classic, toes bilateral neuropathy for this patient. Again, he endorses this prior knee injury that's left him with some numbness. Two months ago, saw a community ophthalmologist without any evidence of ophthalmopathy, no screening evidence of depression. And then in terms of dental visits, his last time was sort of a pre-transplant workup a few years ago. Self-management or education, and nutrition, he's not met formally with a nutritionist. And then I think in the community before coming to us, he had met with a diabetes educator at one point. So relevant social services exposures, obviously, of immigrant status, literacy assistance, then medicine, pharmacy access are issues for this patient. He's been able on the transplant, pipelines to access all of his necessary medications. When we talk about identified barriers to compliance or his treatment success, he's very reliant on his daughter to help navigate the U.S. healthcare system. He himself has limited literacy, but has learned to sort of navigate how his blood sugars are responding to his meals. So we'll talk about his meals in a second, but he's a fairly consistent gentleman. He'll eat the same meals, each day at the same times, which helps. And so he's noticed some patterns based on that with his glucometer data at the time of our initial visit. He does live about an hour out of town. And so when we see him in person, that was sort of our only time seeing him in person. We've done remote care since then, but he comes up with some frequency and gets his labs elsewhere with a mixed picture between seeing us in person and sort of remote care. So in terms of his mealtime behaviors, so he eats really fairly consistently. About 8 a.m. He'll have 2 eggs and a cup of tea. He does have a snack between breakfast and lunch around 10 a.m. He doesn't give any insulin for that. But then his lunch, again, you can see some sugar-free options, but a lot of, also some carbohydrates here, complex carbohydrates, appropriately, but, wheat bread and lentils, sometimes he'll have yogurt. That's it, tends to be his biggest meal in the middle of the day. But then he has a similar assemblage of food choices for his dinner. And then Dr. Earhart, tell me, this is where we kind of stopped on our first visit, and we had a couple management decisions initially. Do you want me to address kind of what we did as a first step?
Why don't you just show the CGM data as where he was at baseline?
Okay. Yeah. So after our first visit, our only decision on our first visit was to place a continuous glucose monitor. We didn't tweak any medications initially. We really just did want to see how he's doing. And so we placed the CGM, did kind of a 2-week trial to just see what the course of his day is looking like. And this here is the initial data that we obtained here. So you can see whenever we look at continuous glucose monitor data, there are a couple important numbers that we look at. The first thing we always check is sort of what percentage of the time is he using the sensor, right? So we got a 77%, 23 out of the last 30 days when we pulled this data from his device. The second thing we look at is the time in range, right? So this patient at the time of our initial touch point with him is only 34% time in range, right? And at 44% of the time he's above range, 180 to 250, and 21% of the time he's very high. He's above 250, pretty low rates of being low. So, and then the last number here is this GMI, which is sort of an in silico approximation of what somebody's A1C is, right? You kind of can draw correlations between average blood sugar behaviors and do an integer, if you remember your calculus, and pull together what you think an A1C will be and as an estimate. So that's the underlying case.
Thank you, Owen. That's a great case presentation. And you had said that he was doing some finger sticks, but didn't bring the glucometer in. My first clarifying question was just, what was he reporting as his range of glucoses via finger stick with that initial presentation?
He says a lot of his basal, so he'll do morning checks. He knows to do fasting morning blood sugars, and those are, that's sometimes where he gets those 80s. You'll get those after exertion, but when we looked at just a few numbers together, tend to be in the low hundreds. But then he says sometimes I'm in the 300s, right? And that tends to be those afternoon postprandial blood sugars that he's checking. So his sort of narrative report about how the glucometer is behaving is, he says, I'm high, I'm in the 300s, but when you look, those aren't his fasting numbers. He tends to be in the low to mid hundreds first thing in the morning.
Thank you for that great information. So our quick recap. So this is a 56-year-old male with type 2 diabetes, end-stage renal disease, caused by both diabetes and hypertension. And now he's been on status post-renal transplant for about 7 months ago, currently on a stable dose of prednisone at 5 milligrams in addition to his other immunosuppression, complicated medical history to include reflux, hyperlipidemia, and a BMI of 30, absolute weight of 105 kilograms. And so, our focus is how do we improve his glycemic concern, and how do we support him in the setting of potentially a lower health literacy, limited English, but a very supportive family. And then, what we have to throw in there, he did have that perinephric abscess, which also could be a reason for worsening glycemic control, as well as his steroids and immunosuppression medication. So these are his medications right here. And as you highlighted, it looks like he's on glargine at 37 units and insulin at 8 units with meals with a correctional scale. And as you saw, his average glucose was in the 200s. The other thing I just want to point out is that you can sort of see that he either is flat or has a downward trend overnight, but then as soon as he eats, he has an immediate rise in his glucose. And I always think going to the individual few days is great. And this is where you can really see that, yes, he does have some of those 80s, like you said, in the morning, but as soon as he eats, his blood sugars significantly rise. And so, the individual characteristics we always want to think about with these patients is, how insulin resistant they are. So with a BMI of 31, fairly insulin resistant. Now, luckily, he has a GFR greater than 60. He's younger. He hasn't had DKA that we know of. His family history in his mom and his father are sort of unknown, but it is sort of telling that both his brother and sister have prediabetes. He does appear to be a vegetarian, and his intake seems pretty high in fiber and veggies, which is great. He does have insurance with his Aetna. His complications is the end-stage renal disease, status post-transplant, the chronic steroid and immunomodulator use, and this potential lower health literacy and being a recent immigrant as well. All these whole body health issues. And, we always start with what is our first question, right? When we see every patient and we want to think about this. Do you believe this person produces insulin? Is this person insulinopenic or insulin resistant or a combination of the both? And what is our next steps, right? So, we believe that he most likely has type 2 diabetes and is more insulin resistant rather than insulinopenic, but he is currently insulin requiring. And so if he does not improve as we add insulin sparing agents, we may want to think about looking ahead his functionality, which would be, as we've talked about, the precursor of insulin in the pancreas, the C-peptide. And just to point out, we don't know how long he had his diabetes for. He was younger at presentation. If he's already had this disease for 10, 12 years in his home country, it would be early 40s with his presentation, since he's already, was in end-stage renal disease and received a kidney transplant. So just something to think about. And then our second question always is what is his A1C goal? And remember, this always changes as his medications, as his life circumstances, as his age, his comorbidities evolve. And right now, he's on a high potential for hypoglycemia with the insulin, and we're altering a lot of things, which may be adding more medication. So I would throw out, in this particular case, I would maybe say for an A1C less than 8, as we're replacing insulin with an insulin sparing agent, and then, he's young, and has had a kidney transplant. If we can get him to an A1C of 6.5 to 7 without hypoglycemia risk, that's what I'd aim for in the long term. And I know Owen's overall clinical question and what he was trying to address with his management is, how do you manage insulin in the setting of chronic prednisone use and other medications which increase insulin resistance? And then how do you add on these insulin sparing agents, particularly in the transplant population? So I have started to add my third clinical question is does his CGM and GMI, which is his estimated A1C, match his hemoglobin A1C data? And in this case, the answer is yes, right? In November, which is pretty close to December, he was 8.2, and then currently he's 8.2. I do question if he was really that well controlled before transplant at 6.6. Remember, he had anemia of chronic disease. And so I would hesitate to say that he has had worsening control. We just don't know truly what his control was before the transplant. But, we do now have data. So in the future, I do think we can believe the A1C and use it as an adjunct for our therapy decisions along with the CGM data. We always talk about non-pharmacologic because we want to be supporting the whole patient. And so, I did want to point out, we've been talking a lot about protein and protein in diet and healthy sources of protein. And so the American Diabetes Association does sort of recommend to get about 0.8 to 1.5 grams per protein per kilogram of body weight, which is about 15 to 20% of the daily calories from protein. And they don't necessarily say there's high quality evidence of going higher than that, but there are some studies that have shown that slightly higher protein, like 20 to 30%, may have some benefit for cravings and satiety. So it is something to think about. And then again, we want to be thinking about for our patients with diabetes and non-dialysis dependent. Our Kidney Association does recommend no more than 0.8 units per kilogram, just because of the potential difficulty of the kidneys with higher levels of protein, although that is a little controversial. And so, these were the newest 2025 guidelines that basically highlight it's not just protein, but this idea of plant-based protein for your protein content. And then again, we've talked about Mediterranean type nutrition and our other sessions. Again, there's rising evidence on each of these and the benefits of them. And so these are just some ideas for your patients for plant-based proteins. And, I was really surprised. Something like edamame has 18 grams in a cup of cooked edamame for protein. Laura, when you're talking about protein content in your patient population, how do you discuss it in an easy way that's digestible that they're more likely to do?
Well, I guess I'm surprised that the ADA did, because again, in obesity, I recently went to Obesity Week. Animal-based protein was higher quality in a lot of the sessions that we had, higher quality than plant. So I guess that's an interesting point that they're making. But generally, I say protein each meal, each snack. With a lot of these treatments, like the GLP-1s, they're eating. They're not going to they're not going to feel as hungry. So protein shakes generally they could use that as a meal if needed, but about 20 to 30 grams of protein.
Great. And it is always hard. I think there is some controversial over protein and where to get our protein from. I think, the idea is we do want lean protein and to avoid red meat as much as possible when we're doing our animal-based protein. Again, this is just to highlight in our transplant population. Initially, they may have higher protein requirements, but several months after transplant, sort of they have a similar amount necessary as those that have not had a renal transplant. And then the other thing, that really struck me was that this person had a 0 depression screening with his PHQ-9, and yet, when you look at everything going on in his life, he's having huge life changes. And so I wanted to throw it out to Dr. Ward, our psychologist who's now on, to sort of talk just briefly about your thoughts and how you'd continuously address this with this patient who does have both chronic disease and a lot of life changes recently completed.
Well, I guess first of all, what I was thinking of was, given his limited knowledge of English, when you're meeting with him, is his daughter interpreting for him, or does he have a medical interpreter? Because one thing to consider is the matter of stigma and speaking about anything that might be, related to depression or anxiety or other types of psychosocial concerns. And so I don't know if there's actually what conversations have taken place with him to learn more about how he's holding up. And so with that in mind, I was thinking about not just looking at depression and really thinking more about the patient's overall psychosocial well-being and quality of life. Though I will say, like, if we're going to look at, psychiatric concerns, like the DSM-5 actually has a cultural formulation outline, which is used to assess cultural features of an individual's mental health problem and its relationship to the social, cultural context and history. So it includes categories such as cultural identity, cultural conceptualizations of distress, and psychosocial stressors. And there's actually like 16 interview questions that could be used between the provider and the patient, or there's also one specifically for like an informant who's like the daughter, who's knowledgeable about the patient's problems and life circumstances. So going back to thinking of this gentleman, having a South Asian background, it's important to be sensitive to the stigma with depression and to, find ways to use language that feels acceptable or comfortable for them. So a common idiom used to describe depression, strain, anxiety, and distress actually is tension or tension. And tension, like it's supposed to embody the multifaceted construct of suffering. So it's often used to express feelings of sadness, worry, and overwhelm without actually using the word depression. And in fact, physicians in South Asia explicitly use the term tension as a way of having discussions with their patients about such concerns. And additionally, South Asian cultures often express emotional distress through physical symptoms. So idioms may focus on bodily sensations like headache, stomach ache, or feeling heavy. So they might refer to having a poor heart or fog in the mind, their heart has fallen, that there's burden of life, and or feeling hot-headed, which sort of reflects like anger and frustration. So other widely used surveys in research and clinical settings that use to assess quality of life across different populations and cultures could be the World Health Organization quality of life measure. They have a brief measure. And then there's also the PROMIS, which is patient reported outcomes measurement information. Again, it's looking at physical, mental, and social health. And then there's also the short form health survey looking at physical functioning, social functioning, role limitations, mental health, energy, fatigue, bodily pain, and general health. So I would, consider not just looking at depression, but again, sort of the overall well-being of this individual, of this patient. As you said, like he's had a number of health concerns. We don't know how long he's been in this country. We don't know anything about his background other than the family history of diabetes and that he was a farmer. But so I would approach it that way, looking more at from those perspectives.
Thank you so much. And I actually love that term to talk about it as tension when we're talking about mood anxiety. And I think that would be a great catchphrase for a busy clinician just to throw in there so
Yeah.
that we ask one question that sort of might get an answer that we would be unexpected based on the PHQ-9, questionnaire. So
Right. And I was thinking, like, I don't know how that was, the PHQ-2 was even administered. Was it translated? Was it using his language, or was he
Yeah.
expected to fill it out?
Oh,
But he
yeah.
doesn't really know
Yeah.
how to read, so yeah.
All great points. And then this next slide, just for time, is this idea of we want to screen earlier, right? We don't know how long our patient has had diabetes, but this was a recent study that showed that up to 50% of patients diagnosed with type 2 diabetes actually had some microvascular or macrovascular complication. And as we know, the ADA has now, since 2022, has lowered the recommendation for starting to screen for diabetes with an A1C at 35. So he is just sort of a push that to remember to screen people because, many people already have complications from their diabetes when they initially present. And that's why we sort of moved to earlier screening. And then we already sort of talked about those medications that don't help us with weight. Additionally, many of those same medications can raise the blood sugar for various reasons. And, particularly in his case, he has two things going against him from a medication wise outside of the gabapentin for the weight gain. He also is on steroids and his transplant medication. So we want to take that into effect. And then finally, before we go on to the insulin management, I'd wanted Faiza to talk about use of statins in immunosuppressant agents, just because we don't want to use quite as high a doses. So go ahead, Faiza.
Sure. So statins are notorious for having multiple drug interactions, including with several immunosuppressant medications. Statins are substrates of CYP3A4 enzyme metabolism and different transporters, including PGP and OAT1B1. And immunosuppressants act as inhibitors of CYP3A4, PGP-1B1, which leads to altered statin pharmacokinetics and increased serum statin concentrations. And these interactions can really increase statin exposure anywhere from 3 to 20-fold, which of course is a really significant increase. The biggest concern is, with increased exposure is the risk of statin-related adverse effects, including myopathy, myalgia, and rhabdomyolysis. The immunosuppressants to worry about are cyclosporine, tacrolimus, everolimus, and sirolimus. Most transplant recipients are typically on one of these medications. So how can you mitigate this risk? The American Heart Association put out a scientific statement back in 2016 with recommendations on how to manage statin drug interactions. And here you can see their dose recommendations for different statin meds when used in combination with these immunosuppressant medications. Some statins should be avoided completely, and other statins, including atorvastatin, rosuvastatin, and pravastatin, are safe to use at reduced doses.
Thank you for that information. I think it's just important to keep in mind because our LDL goals tighter as primary and secondary prevention, but we always have to take the whole patient in account when we're thinking about things. So, and he might be someone we would put on a Zetia or if needed be for a second agent to get to that less than 70 goal and not increase his statin any further. So now let's get to the heart of everything, which, I may think this is the most important because I am a diabetologist and insulin is my thing. But, in his case, right, because the prednisone, which he's taking in the morning, tends to peak early afternoon and then sort of wear off at night, we really want to think about the physiology of what the best insulin is. And we showed both NPH versus like our more 24-hour insulins like Glargine or Basaglar, Tresiba last time. But remember, the NPH has, more like an 18-hour life to it. And so in his case, it may be a better choice of an intermediate acting medication. So then it also peaks when the prednisone resistance is peaking and then sort of fades away as the prednisone dose goes out. And so, and you can sort of see this is that, this is sort of the pattern we may be able to match by using an NPH insulin where he stays pretty flat overnight, but then he needs potentially more insulin later in the day. And so that I'm a weight-based person. So when we choose insulin doses, we always want to think about it in terms of the patient characteristics and then simple math, so a weight-based calculation. And so, right now he's fairly young and his kidney function is normal now. I apologize. His weight is 105 kilograms and currently he's on about 37 units of Glargine a day, which is about 0.35 units per kilogram. And then if he's taking all of those doses, he's approximately on 24 units or 0.23 units per kilogram of prandial insulin, which leaves him at about 60 units a day of insulin, which is just under 0.6 units per kilogram a day. And so this is a good dose of insulin, right? But someone who has a BMI of 31 is on prednisone may require up to 1 unit of insulin. But remember, where do we preference the insulin? We preference it in the prandial insulin. So it may be that he just needs a little bit more of the prandial insulin and a little less of the long-acting insulin if we were just to use insulin. And in this case, just as we talked about how to convert NPH to Glargine last time, we're going to talk about converting Glargine to NPH. So you do use 1-to-1. Some people will reduce the dose conservatively by 20%, but I tend to keep it 1-to-1 just because you are dividing the dose of NPH. And so I traditionally will give 2/3 of it in the morning with breakfast, and then to match sort of the peak, I tend to give the NPH when someone has steroids at dinner time, and I would do 1/3 of that. So I think a great starting dose for him may be somewhere between 25 and 30 units of the NPH in the morning and about 10 to 12 in the evening. Because his A1C is 8.2, and we believe it because his average sugars were in the 200, I do think you could do a 20% increase if you wanted to in the morning dose of the NPH and then see what happens, especially if you weren't adding any insulin sparing agents. But again, what we wanted to highlight from this case is this is the same slide as I used last time, the over basal, right? And so right now where he is, that 0.3 units per kilogram of glargine is probably the maximum dose we can get to, because he was, at the end of it, he's tailing down into the 80s. So we just really have to think about that. But the good news is that he now is sort of stable with his prednisone dose, with his immunomodulator medications. And so this is typically when I think about adding insulin sparing agents. And I used to wait for 6 months before I added insulin sparing agents for my transplant patients. But now, as long as they're stable, I typically will think about it as early as 3 months. And so this person's in a particular window. What we will say, and what I tell patients, is none of these diabetes medications have been really studied very well in the transplant population because they're such a small population. But this was one study that it was 17 patients that looked at GLP-1 receptor agonists after transplant, and overall people did well and had less insulin requirements and low risk for hypoglycemia. And so when we go ahead and add the GLP or GIP GLP, would you reduce the insulin? And I would be okay with just maintaining the NPH at 30, like I said, and likely 11 is fine because the cumulative dose is already a little less. To be conservative, you could always go down on the prandial insulin by 20%, so decrease it to 6 units with meals. But I'd also be okay with holding at the current dose because we can see from a CGM that he really is pretty hyperglycemic during the day. And so the question then is can we get coverage for the GLP and GIP GLP? And so, I just went to the Aetna formulary page, and I was just going to ask Faiza to also comment on this briefly as well.
Yeah, so as a pharmacist, I'm lucky to have access to, our pharmacy system, so I can see exactly what's covered with the patient's insurance. But often what we'll do, if you don't have access to this, we'd recommend just sending in the prescription and have the patient checking with the pharmacy within a week. And then if they're having trouble getting it, it probably needs a prior authorization or the medication's not covered, and then we can try switching to something else. So yeah, the patient can also call their insurance, but I think that's a big barrier for a lot of patients. For this patient, I don't know if they would be able to contact their insurance and sit on the phone and try to figure out, what of the incretin therapies are covered.
Yeah. And what I will say is what you can see from here is typically they are covered, but you have to have a counterindication or be on maximum tolerated therapy of metformin. And so we'd be able to say that he's had some side effect profile from the metformin. And just because he's fairly recent from transplant, we could use that as a reason to step over metformin, at least initially. And then the other reminder is you don't have to have any of the step if the person has known cardiovascular disease in this particular plan. And I think that's becoming more and more common given our cardiovascular data as well. I did look for weight management or weight loss Aetna does not cover it except for in the setting of known cardiovascular disease. So these are all things that, we need a second degree in insurances, but it is an important discussion to have because it's one of our biggest barriers to prescribing things appropriately for our patients. And so appropriately, Owen and his team did go ahead and try tirzepatide. And interestingly, what happened was after one dose, the person develops very severe symptoms, nausea, vomiting, constipation, to the point that he went to the emergency room. And so when he came back to see them in the clinic, his CGM was about the same, because he had to stop their tirzepatide. And so they decided to do a retrial of him. And what they did is they started him on another class, GIP, GLP, because we do find that sometimes people will have strong reactions to one class and feel a little better within a similar class. So this person then got started on some glutide at 0.25 milligrams weekly with just a small reduction in the basaglar to 35, and then because he was fairly hyperglycemic during the day, appropriately a slight increase in his prandial insulin. And you can sort of see looking much better with that change on the very low dose of 0.25. And this is where I want to point out, just because it looks good, this is where we are more aggressive with our insulin de-escalation, right? As we go up on it, because we don't want to have any low blood sugars, because now they're outside of their glucose toxicity, and you're going up to a dose of these GLP, GIPs that are very effective for A1C lowering. And so they did go down to glargine 30 units and up to 0.5 milligrams, and Lispro down to 8 units with meals. And you can see they have kept the patient safe and well controlled in that sort of range we want, like 7 to 8 as we're adjusting medications. But I think the problem is that, what we want to be able to do is hopefully get them off of prandial insulin, but we can't push the dose of glargine anymore because he's well controlled overnight. So again, this would be when I would consider using NPH. You could do the 30 units in the morning and the 10 units in the evening, and increase him to 1 milligram. Versus the glargine, you'll have to reduce him again. I'd probably go down to 25 units when I went up to the 1 milligram. And in this case, I would probably reduce again to 6 units for the prandial insulin. Especially as his weight now is decreasing. He went down to 99 kilograms from 105 kilograms over that 3-month period of time. And so, my summary is that we definitely want to get those insulin sparing agents on board. The titration, I did all the doses because that can be very complex, right? So you do want to make sure you're seeing your patients on a regular basis so they don't get lost at the very lowest dose. And that's sometimes when I use some glutatide a little more preferentially, because there's only 3 pens versus there's multiple doses of tirzepatide. But then the tirzepatide has more weight loss and more A1C lowering. So if I really feel like I need that, I will reach for that in the long term. And always remember, you can always de-escalate the insulin more than you think you need to, but one low blood sugar can be catastrophic. And so I would definitely go down by 20% each time I went up on it. And I'd have a low threshold once I was at the 1 milligram dose, just to half the prandial dose, because I can always add it back. And finally, when the person is on the maximum dose of the tirzepatide, either 15 or 2 milligrams of the semaglutide, I then would think about how much cumulative insulin is he on for his meals, and consider a retrial of an extended release, metformin, which is what I like to do when people have histories of nausea or bloating on it, and then consider using empagliflozin. The caveat is that there is a slight increased risk for like urinary tract infections in the first year after kidney transplant because of the reflux, is what my transplant doctors have said. But there have been small studies of using SGLT2 inhibitors at a year with good effect. So over time, what I would try to do is to replace his prandial insulin with the insulin sparing agents. And so that way, hopefully we will reach his goal on just being on 0 shots a day, or maybe just that NPH in the morning to cover a little bit of that prednisone surge. And so I'll stop here because of time, and I'll just say this ends session 8 of the cardiometabolic echo.